Hello? Hello?
Hello, good afternoon to all the participants and all the speakers. I would like to welcome you to the World Diabetes Awareness Month webinar. My name is Jeremy Rafael, the Director of Academics of AMSA International, and will be your moderator for today's webinar. Today we will have two lectures from two speakers about the bariatric surgery and the insulin usage towards the diabetes type 2 management. As we know that diabetes is a classic problem which causes many problems worldwide, and through many development, the prevalence is still roughly the same, with complications with macrovascular and microvascular complications. Therefore, there is a need for us medical students and practitioners to take a step to get rid of this diabetes through novel approach. And for the first speaker, I would like to invite Dr. Wilfred to present his material. But before, I would like to read the CV of Dr. Wilfred Mui. Dr. Wilfred Mui graduated from the Chinese University of Hong Kong in 1996 and started his surgical training at Prince of Wales Hospital. He received his fellowship of College of Surgeons of Hong Kong, Royal College of Surgeons of Edinburgh, and Royal Australian College of Surgeons in 2003. He received the Lee Shield Gold Medal Award during his exit examinations. In year of 2001 and 2002, he went overseas training on advanced laparoscopic and obesity surgery at the Johns Hopkins Hospital as surgical fellow. His main interests are advanced laparoscopic, bariatric, and metabolic surgery. He pioneered the use of intragastric balloon, laparoscopic gastric banding, laparoscopic sleeve gastrectomy, and bypass surgery to treat obesity and diabetes in Hong Kong. And he is official trainer of intragastric balloon in Asia Pacific region. He is currently the medical director of Bariatric Surgery Center of Evangel Hospital and Hong Kong Bariatric Metabolic Institute. For Dr. Wilfred Mui, I present you the stage. The stage is yours.
Good afternoon, everyone. I hope you can hear me well.
Yes, we all can, Doctor.
Yes. Today, I would like to talk about the surgical treatment for diabetes, type 2 diabetes. To most of the medical students, they may not have heard about this because traditionally, treatment for diabetes is mainly conservative management and medical treatment. But in recent 10 years, we have tremendous improvements and advance in surgical treatments of this particularly chronic illnesses, and it's a huge impact on the treatment of type 2 diabetes. I'm Dr. Mui from Hong Kong, and I'm specialized in the bariatric surgery and upper GI surgery. Okay. So obesity basically is now become a pandemic problem. It is not only affecting the affluent society or the Western developed country or area. In fact, we are actually seeing this obesity is become a worldwide problem. And it is also affecting our Asian patients as well. And as you may aware, we are seeing more and more obesity in the Asia Pacific region, especially as our society become more affluent, and this is a problem not unique in the Western world, but it's become a worldwide problem. So in fact, in Hong Kong or in China, we have observed that there will be approximately 1/3 of patients who are overweight or obese, and up to 1/10 of them have associated diabetes. Next slide, please. So you may wonder, in layman, people may think obesity is just it's not a disease by itself, but in fact it's not. In fact, it is a disease entity by itself. If the patients have increased abdominal obesity, and it will lead to a whole lot of obesity-related comorbidity. To name a few, is what we call like hypertension, dyslipidemia, and particularly type 2 diabetes. And as a result, this will affect our end organ, like our heart, like our microvascular end organs. And as a result, in fact, obesity itself is not just the physical appearance or abnormalities, but it's in fact a disease entity on its own. So in order to alleviate all this kind of obesity-related comorbidity, we have to tackle obesity in a more effective manner. Next slide, please. Yes, there are two types of fat that you may not notice, but in fact, we have two different type of fats in our body. One we call what we call subcutaneous fat, okay, and the other is what we call visceral fat. This, although they are both are fat, but in fact they are different entities. In fact, most of the problem causing obesity is as a result of the visceral fat. This kind of fat cell actually produce a lot of endocrine and inflammatory markers affecting our systems, and is less so in those with subcutaneous fat. So when we're talking about fat, the types of fat are also important. For example, if we just do a liposuction for subcutaneous fat to do a body contouring surgery, say liposuction itself, is not weight loss surgery itself, although it reduce some or flatten some or remove some subcutaneous fat, but it will not affect the visceral fat content. So what we are tackling is we want to decrease the visceral fat, or not only the subcutaneous fat, when we consider treatment of obesity. One thing is central obesity is direct correlations with the visceral fats. Okay, if you look at this gentleman, it may not be too big to some of you, but if you look at the waist circumference, okay, if you look at the waist circumference, it indicates that there are a lot of intra-abdominal fat or visceral fat inside the abdomen and causing problem of obesity. Next slide. This is a study conducted in Hong Kong years ago. Okay, we noticed that. I hope everyone of you know what is body mass index, BMI. Okay, BMI is an index we measure obesity. Is a number index calculated by your weight divided by your height in square meters. Okay, so in Asian, or in particularly in Chinese, okay, we noticed that our risk of metabolic syndrome increase when our BMI start to become above 25. This is particularly a problem in Asia and Asians, because we have different type of this is a different type of fat depositions, and we are more prone to this metabolic syndrome at a lower BMI as compared with our Western Caucasians. So for Asians, for Chinese, we start to realize metabolic syndrome start to be affected when we have a BMI of more than 25. As this is especially true when the diabetes. This is especially true when diabetes. So we notice in Chinese, we start to have problem when the patients have a BMI of more than 25. This may not be the case in Western populations, as the cutoff for BMI is higher than in our Asian populations. So as a result, we have different type of classifications, but basically the same. The one on the left side, upper one, is what we call the WHO classifications of weight. Okay, so this is based on Western populations. Okay, we considered Western populations to become obese when our BMI is more than 30. We consider Western populations to be overweight when it's more than 25 to 30, okay? Normal range is 18.5 to 25. And we classify obesity in different groups. And when it's become more than 40, it's become what we call super obese or morbid obese, or in more than 50, we call it super obese. So this is WHO classifications for the Western populations. But for our Asians populations, we have a slightly different classifications. But basically, one take-home message is we have a lower BMI considerations. Okay, we consider it's overweight when it is 23, and at risk when more than 25, and obesity, and morbid obesity when it's more than 30. And also we take into considerations with the waist circumference. So these are very complicated slides or may not be understood at the moment, but the take-home message is different ethnicity have different classifications. So the reason why we do bariatric surgery to treat obesity is because there are no effective way to treat obesity at the moment. Okay, the role of conservative management of lifestyle modifications or even medications are very limited. So as a result, we have quite a long history of bariatric surgeries in treating obesity. Okay. This is quite an old school and old classifications of different type of bariatric surgery. Okay, on one group, what we call a restrictive type of procedure. Okay, the other group is called what we call a mild substitute type procedure. Restrictive type procedure is in the old days we classified we call restrictive because it restricts the amount of calorie that the patients can consume. Whereas malabsorptive, in addition to a restrictive role, we add a bypass, some sort of intestinal bypass to the procedure that make the patients a bit malabsorptive. So these are the classical old style classifications of bariatric surgery. Well, it's still being used. It's still being used, but as we notice, as we understand this procedure more and more, then we have a different type of classifications or in consider this kind of surgery. Just to give you some names like intragastric balloon, gastric banding, sleeve gastrectomy, gastric bypass, or duodenal switch. These are the relatively most common performed procedure worldwide. For instance, like intragastric balloon, this is not per se, it's not a surgery. We just use endoscopy to put in silicone-made balloon filled with water in the stomach to occupy the stomach volume. It's type of restrictive procedure that helps to patients to decrease the calorie intake to help to lose weight. But these are temporary procedures and is completely reversible. And for example, like this gastric banding, this is the procedure we put a silicone band at the upper part of the stomach to create a small pouch with a port insert at the abdominal wall, so to adjust the pouch size. This surgery was very popular in the past 15 years, 10 years to 15 years. But this procedure become outdated and less commonly performed nowadays because we have more and more development of other surgery. But this is just an example of other type of restrictive procedure. The other type is what we call a sleeve gastrectomy. This is become the very, very popular procedure nowadays. And in fact, in Asia, it's become the gold standard or become the most popular procedure. Instead of putting a band at the upper part of the stomach, we resect the greater curve of the stomach, because the greater curve is distendable. So when we remove this part of the stomach become a tube shape and become more restrictive in nature. So we initially thought this is a restrictive procedure, but in fact, it is not the case. What we understand now, when we do this gastric resections of this gastric fundus, we realize it decreases the hormone ghrelin tremendously, which is an appetite hormone. So after the removal, the hormone decrease and the patient feels satiety earlier. And also, if after this surgery, we have observed a change of gastrointestinal hormone. I don't want to go into details today because we're talking to a group of medical students. We just want to give you a concept. Now, this is not a purely restrictive procedure because apart from restrictive, it creates endocrine change of endocrine or GI hormone in the gut. And now we discover this kind of changes, or what we call metabolic changes, is in fact have a tremendous impact on our glucose homeostasis. So another one is gastric bypass. This is in the Western world, a gold standard for weight loss surgery. And also we discover this is not purely restrictive again, because we bypass the GI tract, and also this procedure will create, apart from restrictions, it create a huge metabolic effect and create a huge increase in dose of GI hormone, helping the diabetes, glucose homeostasis. So we consider this kind of GI surgery, apart from weight loss, it has what we call a metabolic effect. And this metabolic effect is the reason why we are shifting weight loss to treating diabetes. And we realize this kind of GI hormone effect has a tremendous impact on our glucose homeostasis. Another one is duodenal switch operation. And again, this is a very more drastic, more drastic procedure with sleeve gastrectomy and a switch procedure. This procedure again causes huge metabolic effect on our body. So now, in the old days, there are some indication for surgery. We are not operate this surgery for cosmetic reasons. So we need a kind of indications before we consider this procedure for our patients. This is an old indications for NIH, and it's for Caucasians populations. I would have to say this kind of indication is arbitrary. Okay, we just believe when you, in the old days, when we believe your BMI is more than 30, which is morbid obese, or if your BMI is more than 35 with obesity related comorbidities, and also you fail other less invasive treatment, is an indication for surgery. These indications are still hold true, but this is for the indications in the Western populations. As I have said, we have different compositions for our Asian patients. So we have a different type of indications for bariatric surgeries. We're talking about weight loss surgery in Asia. Usually we take it at less 2.5 BMI in our Asian populations. For instance, we suggest surgery if a BMI more than 37.5 or a BMI of more than 32.5 with comorbidities. So the weight loss surgery actually is not for weight loss only. Actually, we have numerous systematic review and long-term outcome. In fact, this the bariatric surgery of whatever kind can actually improve significantly our obesity comorbidities like diabetes, hyperlipidemia, hypertension, and obstructive sleep apnea. And this is proven beyond doubt that bariatric surgery has a huge impact, especially on diabetes. And initially we thought the impact on diabetes is because of weight loss alone. But as more data coming out, at least for the past 10 years, we realized that the reason why the diabetic has much improved our bariatric surgery has a different different reason for it. This is one of the landmark paper back in 2007, looking at the long-term effect of bariatric surgeries on the mortality of those obese surgery. We realized the next slide. We realized whatever different type of procedure, it has a long-term weight loss. The weight loss is long-term, if we compare with the control group of patients, and it translate next slide, and it translate into decreased mortality. Okay, so if we operate on this long obese patients in the long term, actually surgery increase the lifespan of the patients. Perhaps this is the only type of surgery that increase the lifespan of patients. So we do bariatric surgery to reduce weight and help patients to control weight in long term and improve the lifespans. So as we see, the weight loss causing treatment for diabetes is only help in treating diabetes. In fact, bariatric surgery improve and prevent type 2 diabetes. This is from the same group, and we realized if you follow up the patients long enough, the group underwent surgery has a lower incidence on type 2 diabetes in the long term. So in conclusions, bariatric surgery not only induce long-term weight loss, it improve diabetes in the long run, and it prevent it from happening. So in the beginning, we thought this type of surgery, like sleeve gastrectomy or gastric bypass or duodenal switch, the weight loss is the reason why we is the reason why diabetes is improved. But in fact, we now have ample evidence when we do this kind of gastrectomy, different types of gastrectomy or bypass surgery or intestinal bypass or GI surgery. In fact, it will cause alternations of different type of gut hormone. And this improve like decrease in ghrelin, increase of PYY, GLP-1, and all others, this kind of GI hormone. And this kind of hormone is called what we call incretin. And in fact, if we have this change of this kind of hormone, it will increase the insulin sensitivity of the patients or decrease the resistance and increase the insulin secretions. So in fact, this type of procedure not only induce long-term weight loss, it not only have a restrictive or controlled nutrition absorptions or consumptions, and the most important, in fact, is the cause of this GI hormone. This kind of change in GI hormone help to increase insulin secretions and decrease insulin resistance in our patient. As a result, we see we are now doing this kind of surgery specifically for diabetes, but not for weight loss alone. So as a result, in the past, we classified our surgery into like restrictive or malabsorptive. as I said, this is quite an old school old concept. But in fact, we are now classified our surgery, in fact, in the two perspectives. One is what we call bariatric surgery on stomach and on intestine to help patients to lose weight with morbid obesity. Okay, the other group, what we call, is a metabolic surgery. Okay, or specifically for diabetes, it will be called diabetic surgery. Say like metabolic surgery, we call it surgical approach, which primary intent is to control the metabolic syndrome of type 2 diabetes. So when we do that surgery, specific for control of type 2 diabetes, or if diabetic surgery, surgical approach to treat type 2 diabetes. So we have different type of definitions, and we have a change of concepts and change of naming of this type of surgery. So now we have, for recent years, we have compared this type of approach using surgery to treat diabetes to compare with our intensive medical therapy for diabetes. We will have another speaker talking about treatment of diabetes later on in a conventional way. But what the sad thing is about medical therapy for diabetes is the long-term outcome is very poor. In fact, in our local Hong Kong public hospital data, more than 90% of the patients, they cannot achieve good control in terms of ABC in the long term. So there are now numerous randomized control trial comparing surgery versus this kind of intensive medical therapy in treating type 2 diabetes, not for weight loss, type 2 diabetes in the long term. So we recognize that now, in fact, next slide, surgery has a huge impact on, has a more huge impact on glycemic control, and in the long run, after 5 years follow-up, has improved HbA1c level as compared with conventional. And then, of course, it has improved in the weight loss as compared with conventional therapy. So actually, this is the best diabetic treatment so far we have for our patients as compared with the best medical therapy. So surgical therapy, in fact, is better than medical therapy in treating some group of type 2 diabetes. But should we offer surgery for all of our patients? I don't think so, because not all type 2 diabetic need aggressive treatment, or not all type 2 diabetes are suitable for surgery. So as we get more and more evidence and experience, and now in around the world, diabetic organizations have endorsed the use of surgery in treating type 2 diabetes, like the ADA, like the IDF, and like all the European Asians associations of diabetes. They have now different type. They have now all endorsed the use of surgery in some group of patients. So this is a slide which is quite busy, but I just want to help you to go through slowly. So these are the current indications of surgical treatment for our type 2 diabetes. So as I said, surgery is not is not suitable for everybody, okay? But definitely there's some role in some group of type 2 diabetes. So for all patients with type 2 diabetes, okay, as I said, most of them are associated with obesity, okay? We are not talking about type 1 diabetes. We're just talking about type 2 diabetes, okay? For those who are non-obese type 2 diabetes, okay, namely BMI less than 30 in Caucasians or 27.5 in Asians. In general, we will not recommend surgery for this group of patients, okay? But as I said, as we have more and more evidence or confidence or experience, in fact, a lot of surgeons nowadays operate on this kind of less obese patients, BMI 27, 25, 24 patients with type 2 diabetes. As of course, if they are poor controlled. Of course, we are not recommending. This is not a usual recommendations, but as we have more and more evidence, and people are actually more operate on more and more less obese patients. But in general, we recommend not to consider surgery at the moment for this type of less obese patients. Okay, but if you have a BMI more than 30 in Caucasians, of course, if you're very happy, obese, like BMI more than 40 and more than 37.5 in Asia, actually you should refer the patients for consider surgery right away, because if the patient is so heavy with type 2 diabetes, we understand the use of lifestyle modification or medical treatments are very limited, and the outcome is very poor. So in this group of patients, unless they have obvious contraindications, we usually refer these patients right away to surgeons to consider whether this patient is suitable for this kind of metabolic surgery or bariatric surgeries, because the patient is so fat and also with type 2 diabetes. And for patients with class 2 obesity, like not so obese, of course, we usually initiate optimal lifestyle therapy first. This may take a year, a few years to observe, see whether patients improve her lifestyle or medical treatment. But if after a period of time, if we see patients have poor glycemic control, we should recommend surgery. Of course, even with patients with adequate control, we may still consider surgery in some individual, because in the long term, we know this group of patients will not have good outcome. So we can also consider surgery for this group of patients. But for class 1 obesity, less obese patients, of course, we should always recommend optimal lifestyle medical therapy, and consider operate on this group of patients if they have poor glycemic control. And if they are able to control well, we may put the patients in conservative management at the moment. Okay, so this table summarizes the algorithm, how we approach our surgical treatment for our type 2 diabetes. In short, we should not consider surgery right away, especially in very small patients. In obese patients, if they have poor control, then we should consider surgery. Okay, even if they have good control in extreme obesity, we should consider for surgery as well. Okay, so I hope you understand this algorithm, and these are the current recommendations from our Bariatric and Metabolic Society. And this, I'm sure you, this may change in the future, okay, as we have more and more safe surgery in the future, and this may actually will changing in the future, certainly. So, in conclusions, obesity, the disease itself, is not a physical problem. Okay, it's a physical problem, but it's not. It's a disease and causing numerous long-term morbidities and decreasing lifespan. Conservative treatment and lifestyle modifications are essential in treating obesity, but sadly not effective in severe obesity. Bariatric surgery is now very mature and well-established intervention. This is especially true in the 1990s, when we have minimal invasive surgery. We can now do bariatric surgery in a keyhole surgery, and with minimal morbidities. Okay, So it become more and more popular for the past 10 to 20 years as the technique of keyhole surgery become more mature. Type 2 diabetes affecting about 1/10 of our populations in Hong Kong and is strongly associated with obesity. We observe if you want to have a better control of type 2 diabetes, you have to control the obesity. The problem is there's a high failure rate for and suboptimal control by conventional therapy, by medical treatments, and by lifestyle modifications for type 2 diabetes. And metabolic surgery and or diabetic surgery are very viable options for suboptimal control diabetes associated with obesity. Okay, so this is my presentations today, and this serves as an introductions to all of you. Hopefully in the future, when you go through all the clerkships and become especially in different, and you will hear more about this, and we can discuss more in depth in the techniques and all those surgeries in the future. So yes, that's it for my presentations.
Thank you very much, Dr. Wilfred Mui, for the presentations, well prepared and well delivered to us all. And now we will be having 5-minute breaks for the second presentations, and we will be beginning at 15:45 in GMT +8. So we will have 5 minutes break, and we will begin in 15:45 in GMT +8. Thank you.
I'll try to answer some of the
Okay, thank you participants for waiting and taking a break. Now we are entering the second sessions of the lecture by Dr. Wismandari Wisnu. I will read the CV of Dr. Wismandari Wisnu. Dr. Wismandari Wisnu is from Indonesia and obtained his medical doctor degree on 1998. And he continued to be specialist in the internal medicine in 2009, and he continued his fellowship in the endocrinology and metabolic. And Dr. Wismandari Wisnu have several publications focusing on the diabetes and thyroid disorders. And she is a member of Indonesia Endocrinology Society, Indonesia Internal Medicine Collegium, and the Metabolic Endocrine Division of Cipto Mangunkusumo National Central Hospital of Indonesia. To Dr. Wismandari Wisnu, I would like to present you the stage.
Thank you very much, Jeremy. First, I would like to correct your words that I'm a she, I'm not a he. Okay, thank you very much. So, Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for inviting me, and thank you very much for AMSA, of course. Today, I have a task to speak about diabetes and insulin. You asked me to talk about the new insulin. So what's new about the insulin therapy in type 2 diabetes? So let's start. So this is my title. And as I mentioned before, I'm from Indonesia. I'm from Universitas Indonesia, and I work in Cipto Mangunkusumo Hospital. And this is my disclosure that I have received honorarium as a speaker, consultant, and support for research, and also attendance at educational meetings from many pharmaceuticals company. So before we talk further, I would like you to see. Yes.
The screen is not
Hello.
shared.
Oh, really? How come? You see it now? Jeremy?
Yes, now we can see it clearly.
Okay, thank you. Thank you very much. Okay, so sorry about that. So this is my title. This is we're going to talk about insulin therapy for type 2 diabetes and what's new about that. So this is my disclosure. I have received honorarium from many pharmaceuticals company. And before we talk further, I would like to see about this thing that actually this is the worldwide challenge of glycemic control. So it's not just about our country, it's not just about your country, but actually this is worldwide. We can see here in type 2 diabetes, and this one on the right side, this is about type 2 diabetes. All over the world that you see the A1C is still high. This is my area. I believe this is your area as well. But unfortunately, I don't see Indonesia here. So maybe your country is here, China, South Korea. You're still above the target that we are aiming, that is still high, about 7.8, and also in South Korea still above 8, and also in Indonesia still around 7.8 as well. So second data that I want you to see is actually how important the A1C control is, because if you control the A1C, that actually is going to reduce microvascular complication, and also it's going to reduce long-term cardiovascular rates if implemented in newly diagnosed patients. And at the end, it's going to make a reduction in diabetes-related mortality. And besides that, if you control the A1C, it's going to reduce the total diabetes-related costs. As you see, if you control the A1C into below 7 continuously for about 1 year, the result is going to be reduction 25% for diabetes-related treatment costs, and which include the 22% lower diabetes medical costs and also 28% lower diabetes pharmacy costs. And that's, of course, is something that we want. So besides that, its challenge is achieving good glycemic control. It's also a challenge if we lower the A1C, there will be another problem comes, which is hypoglycemia. So more complex of the regimen is going to be more higher, having a possibility of having hypoglycemia. not even a real hypoglycemia, but also fear of hypoglycemia is already a problem for us. As you see here, if we have no symptoms, mild and moderate and severe, so the increasing of having fear of hypoglycemia is getting bigger and bigger. So this is the proportion of patients like taking insulin at prescribed time or meals every day. They're going to have 27.6 complex of the inflexible regimens. And the number of injection, the more the injection, then the more complex of the regimens. And also so on, if you want to have a complex regimen, then you're going to live normally is going to be quite difficult for someone who thinks that complexity of the insulin regimen is not good for your life. So therefore, there is a need for new insulin formulations to overcome these challenges of complex inflexible regimens and also a fear of hypoglycemia. What kind of insulin is that? So this is the first insulin that I want to show you. This is the new insulin that we have now. I don't know about in your country, but in my country, this insulin is not, it's just be here for about maybe 2 years or 3 years. It's not that long comparing to your country, I think. So this is the IDEC-ASP co-formulation. What is that? So this is a co-formulation of insulin degludec, which is a very ultra long insulin acting with the insulin aspart, which is the short acting insulin. So there are 2 insulin in one pen. So the other one, the one insulin is aspart, which is a hexamer, and it's contained of 30% of the insulin. And the other one is insulin degludec, which is it's a dihexamer, which is contains 70% in the pen. So how does this make the better insulin comparing to the older one? In the formulation, we know, as I mentioned before, that the IDEC as having 2 insulin at the same pen. So the degludec or the long acting is 70% and the short acting is 30%. The degludec is dihexamer. So what does that mean? In the formulation, in the pen, they're going to be a dihexamer. But if you inject it into the subcutaneous, then it's going to be slow dissociation, and it's going to be like monomer, very, very slow reaction. And the other one is the aspart. As we know, the aspart is the very short acting. So when you inject it into the subcutaneous, so the dissociation will be happening very rapidly. So this is what happened. This is the IDEC-ASP co-formulation. Okay, this is the degludec. What is the color of this? Okay, blue one. Blue one is the dihexamer, which is degludec, and the orange one is the aspart, which is hexamer. When you inject it subcutaneously, this is what happened. So they're going to be in a depot in subcutaneous, but also phenol diffuses very quick, and insulin degludec dihexamers will be linked up via single side chain contacts to form a long multi-hexamer. So they're going to be together, the dihexamer into the very long multi-hexamer. So that makes the degludec is very, very stable in your cutaneous. Say that they're going to make a depot in subcutaneous. On the other hand, on the aspart, the zinc diffuses slowly, causing individual insulin degludec. Sorry, this is still degludec. So disassembled and releasing the monomers very, very slowly. And what happened in aspart? In the aspart, they're going to very rapidly dissociation into the rapid insulin. And this is what happened in the pen. In the pen, the degludec, as I mentioned, is a dihexamer, and the aspart is the hexamer as well. But when you inject it, can you see the profile? It's going to be different. That in the subcutaneous, the dihexamer change into the multi-hexamer, and the aspart from the hexamer change into the monomer. What is the pharmacological difference between the insulin co-formulation and the premix. I hope that you have heard about the premix insulin, and actually this is an older insulin. So this is the difference. You can imagine what's the difference, because they're already the same insulin. There are two insulin, which is one is the short acting and the other one is the long acting. But no, they are not the same. What's the difference? The core formulation is involved mixing two biological active solutions together in the fixed ratio combination. As I mentioned, this is a declodic and iSpark. So it mimics the physiological insulin secretions very, very closely to in our body. So, and also one thing that's really important and it's different than the premix insulin is it doesn't have any soldier effect. And the variability of the protaminated premixed insulin, thereby reducing the risk of hypoglycemia. And this is a very big difference between the co-formulation and the premix. There is no shoulder effect. And simplify the insulin regimen without requiring resuspension. So as you know, if you have a premix that you have to resuspension, you have to do it like this over and over again, at least for 20 times, then it's going to make a real suspension. But for this one, you don't need to do that. And for the premix, that involves a suspension in one biologically active solution, in one insoluble biological inactive precipitate in the fixed ratio combination. So actually, in one pen, you're going to have biphasic human insulin and protaminated aspart. So the limitation of the premix is they're going to have a variability, quite a big one. So the glycemic control is going to be quite difficult to have in control because the variability is quite wide. And it's also incomplete 24 hours basal coverage. And the other one, they need to be resuspension. So you have to do it mixed all over and again about 20 times. So how does it work? This declodic and aspart, they work separately. I'm going to tell you about the declodic works. So when you injected the insulin for 10 units, that's the recommendation of the insulin when you start declodic. You start with the 10 unit. What happened in the subcutaneous? When you inject the 10, actually the one who's going to be in the circulation is only 50% of it. So the insulin which going to the circulation is only 5 units. And when you injected when you injected the day after that, so 10 units again. So 10 unit for today is going to be plus with the 5 unit from the yesterday and 50% from the 15 units, then it means it's going to be 7.5 in your circulation. And the day 3, when you injected 10 units, so plus the 7.5 from the circulation, so it means 7.5 plus 17.5, so it means around 25%. So then it means 50% of it is around 9 units. So on the 4th day, when you injected 10 units, it means 10 plus 9, and then you're going to divide it into 2 or 50%, then you're going to get 10 units. So actually on the day 4 or 5, then you're going to get the real 10 units. So before that, on the day 1, 2, 3, you're not going to get the 10 units that you really want because they need time to be stable in your circulation. So be careful. When you inject the declodic in the first day, on the second day, don't get too hurried to increase the dosage because it's not in a stable in the circulation yet. So the elimination of any insulin follows first order kinetics, and therefore there is no stacking for declodic. So the outline, actually, I want to show you how to make the IDEC as an initiation, and the second one, how to make the IDEC as a switching insulin. First, for the initiation, which patient who is very matched with the IDEC as an initiation, sorry. So the characteristic of the patient, first, for the drug naive patient who has the symptom of hyperglycemia, for example, polyuria, polydipsy, polyphagia, and also decreasing of your body weight. So that is the character for the patient who is very matched for initiation of IDEC-ASP. And the other one, high carbohydrate intake. That is very, very much in my country because Indonesia has a very high calorie and also high carbohydrate intake. So it's very much for people in Indonesia who's going to initiate the IDEC-ASP. And also patient with a high A1C and high postprandial excursion. So on the second characteristic, they're going to be patient with insulin naive. So a patient who's already on a metformin with a dual or triple oral therapy and not in control yet, then this is a very good candidate for someone who is going to initiate the IDEC-ASP. So before we go further that we're going to prescribe or we're going to give the therapy for the patient for the initiation of IDEC-ASP, of course, right now we have to do everything, everything based on the reference. So this is the reference. We learned from the Onishi. This is the study from Japan that patient with the insulin naive, but they're already in oral anti-diabetic. They split into the two arms, first arm with IDEC-ASP and the other one with the iGlar U100. This is the inclusion criteria, and this is something that we need to consider to stop as sulfonylurea, DPP-4 inhibitor, and also glenites that we're supposed to be discontinued on this study. So this is the result. So on talking about fasting plasma glucose, that actually if you compare IDEC-ASP with the iGlar 100, it's actually similar. But you have to remember, as I mentioned before, IDEC-ASP is only 70% of it contain the basal insulin. But so actually to get this A1C or to get this fasting plasma glucose, you need only 70% of the basal insulin. And what about the postprandial? The postprandial, we can see here, it's very significantly different, especially at night, because on this study, the patient usually injected at pre-dinner. So this is what you see, very different if you compare with iGlar 100. So after you see the postprandial and the fasting plasma glucose, then you see the A1C. The A1C reduction, actually, you see the superior of reduction, the A1C, if you compare IDEC-ASP with the Glargine 100. And also for the total insulin, actually in this study, you see the total insulin is almost the same, it's 28 and 29. But again, you have to remember that actually it's only 70% of it, which is the basal insulin. So after we talk about efficacy, now we talk about safety. We know that we want to be below 7% of the A1C. So this is what happened. Almost twice patient who gets or who achieve target, which is below 7%. But if we compare with, if related to the hypoglycemia, then we want to be below 7 without hypoglycemia. Still, the IDEC-ASP having twice higher patient who achieve the target very safely. And if you see the confirmed hypoglycemia, the comparison is about 27%. And if you compare with the nocturnal, then the difference is about 25%. And one thing that we have to consider about the simplicity, is it simple? Yes. Because if you start the OID into the insulin, then you need to be in the two-step for it. But if you go from the OID into the IDEC-ASP, then you need to go only for one step. So more simple, yes. So how are you going to start it? The dosing, you have to remember as the initiation, you have to administer once daily or 2 times daily in the main meal. You have to administer alone, or you can do it with a combination with the oral. And the starting dose, it should be around 10 units. And how you're going to titrate is very individually. If it's already in the target, then you maintain the dosage. If it's still above target, then you increase the dose into about +2 or +4. Then it's below target or you have hypoglycemia, then you reduce the dose until about 2 units. Remember, when you adjust the dose with the IDEC-ALS, then you need to make sure that the increasing dosage based on the fasting plasma glucose, not based on the postprandial fasting. So the fasting plasma glucose target is very, very individualized, and do not increase the dosage if you have a hypoglycemia and you have twice daily dosing. Consider to increase the dosage only one at the time weekly. So to make you more understand about what is this, then we go for the case. This is the case first, that a man 59 years old, who is consulted to me by the surgeon. He has been diabetic for 10 years with the sitagliptin and metformin and glipizide for 10 milligrams. He is insulin naive. And you focus on the A1C, the A1C is below, it's about 9.1, and the fasting is about 221, and the postprandial is 262. The problem was type 2 diabetes with obese, dyslipidemia, hernia in the cervical, and chronic kidney disease in the stage 3A. I was thinking of having IDEC-ALS because this patient actually is planned into the surgery. So I have to make sure that the blood glucose of this patient is in control. So I start the IDEC-ALS for 12 units. If you remember, the plasma glucose for fasting is above 200. So I start with 12, not 10. The sitagliptin and metformin, I continue, but I stop the sulfonylurea long-acting. This is the self-monitoring blood glucose after he discharged. He contacted me by WhatsApp, and this is what happened. Only in about 3 or 4 weeks, the fasting plasma glucose is already in control with the dosage of IDEC-ALS around 18. So he came back to me about not even 2 months in August, and he go back to me in October. Can you see the A1C is reducing from 9 into 7.6. I'm so happy with it, and also the patient. And you can see the fasting is already reduction into 142, and the postprandial is 176. So the problem is still the same, but I make a modifications a little bit for the therapy, that I switch the sitagliptin and metformin into 1 tablet and plus metformin XR 1 tablet. So that's how you initiate. And how about for the switching? This is what we know right now from basal bolus is a very complex regimen. So you see, now patient using OAD, and if it's not controlled, then you go for basal plus OAD. If it's not in control, then you plus one aspart, and if it's not in control, then you plus again until it's basal bolus, 1 basal in 3 bolus. This one makes you having a more complex regimen because you have to inject 2 or 4 injections a day. So you need more education and also more monitoring. So lead to complexity, and that will lead to lower adherence. 57% of insulin, so 57%, they said that the insulin patient reported the intentionally insulin omission. And also 20% of the patient reported skipping injection sometimes or often. So this is the characteristic patient who is very matched for the switching of IDEC-ALS. The people with type 2 diabetes with inadequate control with basal insulin, with nocturnal hyperglycemia, if already in basal insulin. This is a simple. Is it more simple? We can see here from the basal aspart 1, 2 aspart, and 3 aspart, you're going to make 1, 2, 3 steps. But if you do with the IDEC-ALS, you only make 2 steps. And the injection here, you're going to need 4 injection, and this one you're going to need only 2 injection. So as a previous one, if you want to start something, it has to be reference on it. So we can learn from Phyllis Simicas. This is a study about how you switch the insulin from oral or also premix. They switch into the IDEC-ALS into, and the other hand, in the IGLAR U100 plus aspart. So this is the regimen In the first 26 weeks, you're going to make 1 injection per day plus or versus 2 injections per day. And continue into the 38 weeks, they compare 2 injections per day, comparing into 3 to 4 injection per day. So this is the curve. For the first 26, you're going to see the difference is around 0.07%. This is only 1 injection, and this is 2 injection, and they continue into until 38 weeks. This is 2 injection comparing to 3 to 4 injection. Sorry, and you see here the total insulin is completely different, and the number of injection is also completely different. You need only 1.62 injection for the iliac asp, and you need 2.85 for basal bolus. This is the nocturnal hypoglycemia. You know that we're really scared about hypoglycemia. If you compare the basal bolus with the iliac asp, that this one in the first 26 weeks, 10% lower rate with the iliac asp, and if you continue is greater number is 14% lower rate with iliac asp. And what about nocturnal hypoglycemia? It's more scary than just the hypoglycemia. The first 26 weeks is lower rates, 45% with iliac asp. And if you continue, it's even greater, that is 39% lower rates with iliac asp. So how do you switch basal bolus or whatever you have before into the iliac asp? This is something that usually I have this kind of questions, how you switch. So this is from basal or premix once daily. If you want to switch into iliac asp, then the switching dose, it will be 1:1. So similar dosage. If you switch from BID, basal or premix, then you're gonna have splitting dose of iliac asp, then the switching is 1:1 as well. And from the basal bolus is really individual, but the main point is the same basal insulin. So this is the case 2. I'm going to show you how to switch. This is a patient who has a long-standing diabetes, more than 40 years. She also has a hypertension, dyslipidemia, CKD, GERD, and also osteoarthritis. Patient with insulin since 15 years ago. And once this patient with a basal bolus and A1C is around 7.8 until 9. And currently she used premix 12, 6, 10 units daily. But there's something that we need to point is she suffered hypoglycemia several episodes. From the physical examination, we can see that blood pressure is still quite high, and the A1C is 7.8. Actually, it's not that bad for someone who has 40 years diabetes, but she suffered several episodes of hypoglycemia. That is something that we need to point. And the fasting blood glucose is around 155, and the postprandial is 131. So I stopped the premix insulin, and I start the iliac asp 20 units and the aspart in the morning once daily. So this is the SMBG. We can see here I increase the iliac asp slowly, 1 by 1. I mean 2 steps, 2 units per increasing. And this is what happened after weeks 12. The fasting plasma glucose is very good. It's around 112 or 106. And this is the last dosage that she has been using until now. And this is the lab test that she has for 3 months, 3 months after the first one. On May, the one that I showed you before. And after 3 months, the A1C is reducing until 6.7. I know in your mind that you would ask, is there any hypoglycemia with that kind of A1C? The answer is no. You can see the SMBG here. There is no number below 100. So she's very, very safe actually. So the patient is happy and also the doctor, and without no hypoglycemia and also no weight gain. And this is a summary, something that we learned from Onishi and Filisimica study, that with the IDEC ups in the largest meal, that we're going to have a reduction in A1C, even a superior in Onishi and non-inferior in Filisimica's, and higher patient who achieve target safely with IDEC ups that happen in Filisimica's, and less number of injections versus basal insulin or basal bolus to achieve similar A1C that we can learn from Filisimica studies, and the significant decrease in rates of confirmed nocturnal hypoglycemia that you can learn from both studies. And the last one is significantly lower to total insulin dose that you can learn from Filisimica's, and fewer injection with IDEC ups in Filisimica's as well. So I think that would be my last slide. Thank you very much for your attention. So let's have discussion. And before that, so I'm going back to Jeremy. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Wismandari, for the wonderful presentations about the insulin of choice for diabetes type 2. Now we are moving directly to the question and answer sessions. Let me share the screen. And now Dr. Wilfred and Dr. Wismandari are welcome to answer the questions, as I will read the questions. First one is for Dr. Wilfred. The question is from Muhammad Syed Boska from AMSA, Bangladesh. What is the best investigations to calculate the amount of unhealthy fat in the body among different age groups?
Well, practically, there are other methods to invest different type of fats in the body, but it's not commonly used in daily practice because most physicians we just use a BMI as a crude guide to the measurements of fat. There are different type of machine measuring the fat percentage, and I think maybe we should ask the physicians to give me more input on regarding the practical use of different type of investigations to investigate different type of fat. But in general, for practical daily use, most physicians will stick to the BMI. Any input from the other physicians?
Okay, if there's none, thank you very much. And we move to the next questions. Is keto diet is a healthy option to lose weight in a long term?
I leave it. Maybe I should answer those questions specific for bariatric surgery or metabolic surgery. These are more general.
Okay, let's move to the questions that's more related to the bariatric surgery. From Muhammad Syed Boska, what is different lifestyle modifications we need to do after different types of bariatric surgeries?
Well, but patient received after bariatric surgery is not. It's no difference from other normal patients. We usually advise normal lifestyle. Healthy lifestyle, exercise in both normal patients or patients underwent bariatric surgeries. So in fact, there's not as we should not that when we talk about diet, there's something we should take note in different type of procedure. But in terms of lifestyle, I don't think that there will be a major difference between normal patients or patients underwent bariatric surgery.
Okay, thank you very much. We are moving to the next questions. What are the chances of malignant change in the alimentary tracts following the bariatric surgeries?
Bariatric surgery will not causing GI cancers. Okay, although theoretically, say like in sleeve gastrectomy, if we have more reflux, theoretically maybe in the long term we may increase the chance of Barrett esophagus or esophageal cancer, but these are very, very reported, and I don't think there's any strong correlations. And in fact, if we have long-term weight loss, actually we decrease chance of GI malignancy.
Okay, thank you very much, Dr. Wilfred, for answering the first three questions. Now we are moving to the first three questions for Dr. Wismandari. From Muhammad Syed Boska from Bangladesh. What is the cost difference between the new IDEC ASP and other previous insulin formulations, please?
Okay, thank you. Thank you very much. Oh, sorry. Yeah. Thank you very much for the questions, Muhammad Sayed Boska. So, if we talk about cost, then we have to also consider the cost for the complications. For some reason, people always think that the price of the drugs, for example, insulin, it's not just about insulin, it's also about oral, that it's actually you think that this is more expensive. But if you compare, if you use this one, then you're going to avoid or you're going to prevent a complication. For example, you can prevent the cardiovascular complications, which is going to lead you to the catheterization, or you're going to have a bypass surgery. Then actually the cost is lower. So if you think about cost, don't think just about the price of the insulin or the oral drugs, but also you have to compare about what kind of consequences that you're going to get. For example, if you use this one, maybe it's a little bit expensive than the previous one, but if you can prevent something, it's going to be cost more than you not. If you don't use the insulin or oral drugs, then I think the cost is relatively lower. So it's not just about the price of the oral drugs or the insulin, but also about the complications. Because 90% of the cost of diabetes is related to the complications. Only 10 or 20% of the cost for the whole package of diabetic patient is related to the drugs. So can you imagine if we prevent the 80 or 90% of the cost to make it better so we don't go to that direction? I think that would be a nicer cost.
Okay, thank you very much. We are moving to the second question from the same participants.
Okay.
What are the efficacy of different non-invasive insulin therapies versus the conventional injectable insulin formulations?
Sorry, I don't understand about the efficacy of different non-invasive. Um,
Okay, maybe the
Conventional.
participant can make the questions clearer on the chat log. We are moving first to the next questions
Okay,
from
thank you.
Lowinus in Indonesia. Is there any special or notable indications for the usage of IDEC apps on type 2 diabetes patients, or it is free to use as long as the patient is indicated for insulin therapy?
Yes, actually, I mentioned in my presentation, but it's okay. I can tell you again because this is something that you need to remember. If you want to use the insulin, make sure that the characteristic of the patient is very matched with what kind of insulin that you're going to prescribe. For example, in IDEC apps, you're going to have one basal insulin and one postprandial. So if you have a patient with the peak of the excursion of the postprandial glucose is quite high, then this is the best candidate for someone who can start the IDEC ASP. And for someone who is very high A1C and also with the oral therapy, but it's not in control yet, then you can start this IDEC ASP. So basically, it's the same like when you think about when you're going to initiate the insulin, it's not just about the IDEC ASP, but also in any other insulin. If you want to start it, just think that she really needs it or he really needs it. For example, there is contraindication for there is contraindication for the oral. The A1C is really high. There is stress metabolic condition, for example, in the septic condition. Then you can start with IDEC ASP.
Okay, thank you very much, Dr. Wismandari. Now we move
You're
to the next
welcome.
questions from Brenda.
Mhm.
Considering the fixed ratio of IDEC and ASP in the co-formulations, would there be any challenges in dosing and intensifications? How to effectively tailor this to suit every patient's conditions? Thank you.
Yes, the challenge is it's happening when you deal with our populations. I don't know about Hong Kong, but in here, we eat carbohydrate very much. I think it's the same. Is that right?
Yes, it is the same when
I
we
think
eat
it's the
rice.
same. Okay. Okay, so we eat carbohydrates very much. So we eat carbo in the morning as a breakfast, at lunch, and also at dinner. So this is very challenging for someone if you want to use IDEC AS, because in IDEC AS, we're just going to give in a two or one biggest meal. So if we think about ourselves, that maybe our biggest meal is the three meals. All of them is the biggest meal, so it's going to be challenged. So you have to make sure that between between these three biggest meal, then you have to choose the two biggest. Okay, so this is the challenge. So you need to choose only twice. But actually, if you can choose between once daily or twice daily, I choose to be once daily. It's better, because if you split into two dosage, then it means the content of the postprandial insulin is also going to be less. So for someone who eat carbohydrates quite big, it's not going to cover your postprandial blood glucose then. So once daily is the better choice for someone who's going to use IDEC-AS. So the challenge is it's going to be difficult for someone who eat carbo for the whole day. So make sure that you educate the patients.
Okay, thank you very much. Now I am moving to the free question sessions. If anyone want to ask a question, please raise hand on the Zoom participants. I will allow you to unlock the video and unmute. If there are no questions, I will be moving to the next sessions. Is there any questions? Please raise the hand.
Jeremy, can I add a little bit more about the questions before the previous one? The one who asked about the diet, specific diet after doing the surgery. Maybe you have to remember, if you do the bariatric surgery, that you're going to have a patient with deficiency of the vitamins. So you need to make sure that they're not deficiency in any kind of vitamins. Usually in the fat soluble vitamins, they're going to be decreased very, very much, and it's going to be significantly this kind of patient having like deficiency. So make sure they are sufficient. So especially for the first months after the bariatric surgery, then you need to give additional vitamins from outside. Make sure of that.
Okay, thank you very much. Now we are having one question first from Muhammad Faruqi. I will allow Muhammad Faruqi to unmute and start the video, please.
Okay, thank you very much for the speakers. I would like to ask specifically to Dr. Wisma. Thank you, Dr. Wisma, for your interesting presentation. I would like to ask about the IDG ASP. Is there any different outcomes when we do the treatment for a patient with diabetes type 1 and diabetes type 2? And the other one is that, is it possible if the use of IDG ASP is going on to other continents, like in global usage? Because I see from the journals that it is mostly, most of the journal is published by people from China and India and other Asian countries. Thank you.
Okay. I answer? Oh, okay.
Yes,
thank you.
yes, please.
Okay. Thank you, Ruki. So maybe I answer the second one first. Yes, because as I mentioned, that is very matched with someone who eats high carbohydrate diet. So that's why they very match with the people in Asia, because we eat carbo a lot more than protein. So that's why if we go, if we learn from the study, then the study is very, very much with our population, because most of the study it happens in Asia, as you mentioned, in China, in Japan, in India. So this is because the population has a very high intake of carbohydrates. And first one, the outcome. Are you saying about the cardiovascular outcome, or what kind of outcome are you talking about? Oh, sorry, I don't hear you.
Okay. I cannot unmute myself. So I think it's just a specific efficacy on the drugs if we're treating the person with diabetes type 1 or type 2, or maybe other clinical manifestations that maybe come out if we're treating patients.
Okay, so this is quite new insulin, so we don't have so much studies about the outcome. But if you talk about the outcome of reducing the A1C, yes, we do a lot of studies who's talking about the outcome of reducing the A1C, and the reducing of the A1C sometimes is better, sometimes it's just equal, but it's not worse than the previous insulin. If you compare the hypoglycemia, in so many studies, in any studies shows that actually the hypoglycemia, for confirmed hypoglycemia and also for nocturnal hypoglycemia, it always, I mean, always showed that actually using IDEC apps is a lot better when you use the conventional insulin. So if you try to avoid hypoglycemia, IDEC apps is a very good choice to give for someone who has a hypoglycemia. As we know that for someone who has type 1 diabetic, he always get the hyper and also hypo at the same time. So the glycemic variability is really wide. So this one is a very good candidate for someone who is switched into the IDEC ASP. So I have some patient with type 1 diabetes, but yes, the study is not as many as type 2 diabetes. But if you say, is it better? Yes, it is better for type 1 and also for type 2. But if you ask for cardiovascular outcome, they don't have it yet because it's still new.
Okay, thank you very much for the answer, Dr. Wisma. The next live question and answer sessions will be conducted after these 3 questions. The questions number 1 is from the Samyama in India. Does bariatric surgery guarantee permanent weight loss, and what are its complications? I think it's already answered in the lecture, right, that the surgery guarantee long-term weight loss, and the complications maybe Dr. Mui can explain, please.
Yeah, we are not guaranteed long-term permanent weight loss. Every procedure there will be, to a different extent, with some weight regained. Okay, but in general, we have most procedures have more than 50% of excess body weight loss in long term. And in terms of complications, there are different procedure specific to different different complications specific to different procedure. So in general, for GI surgery, we are afraid of leaks, abscess, or we have to, especially for obese patients, we have to be careful about the general anesthetic risk. So it's not a guarantee of permanent weight loss. The weight loss is long term, but we will expect some weight regained in the long run. But most people have quite a good weight loss in the long term.
Okay, thank you very much, Dr. Wilfred. We move to the next questions by Laurencia from Indonesia. Considering there are many comorbidities in obese patients with metabolic syndrome such as GERD, are gastric ballooning, gastric sleeve, and so on might increase the chance of Barrett's esophagus and other possible metaplasia caused by chronic GERD.
GERD is a real problem in sleeve gastrectomy. Okay, it is not as common for other procedures. It's specific for sleeve gastrectomy, and theoretically it will increase chance of reflux or even Barrett's esophagus. But the report of adenocarcinoma changes in the lower esophagus is very rare. So I don't think reflux is a problem. Sometimes we may need to convert to other procedure in sleeve gastrectomy, but I think for cancer changes or metaplasia is we have very rare incidents for it.
Okay, thank you very much, Dr.
Is safe, especially for children. Okay, bariatric surgery is now very safe. Okay. It's like the risk is like doing a gallbladder surgery. The mortality rate should be less than 0.1%. Having said that, you have to understand we are operate on very relatively sick patients or high-risk patients. So in fact, I always tell my patients, it's not the surgery is safe or not, it's the patient, is it safe or not. Some of the patients are a lot of medical health issues, and then we have to check the balance between the risk and benefit, especially for general anesthesia. For children, we still don't have a uniform recommendations for children, but we actually lean on more cautious side when we offer surgery, especially in children. Okay, and then we are quite a number of people in teenagers asking for surgery. So I think we have to be tailor-made or individually assessed for the suitability.
Okay, thank you very much, Dr. Wilfred. I think the last questions in the slides is dedicated to Dr. Wisma. What change should be made in diet and lifestyle of overweight people to avoid hypoglycemia and change of diabetes at the same time, please?
Okay, I think it's maybe a little bit related to Dr. Mui's presentation, because if it's not overweight, so if it's obese, so maybe I can refer my patient to Dr. Mui. But he was asking about the overweight. So overweight, they don't do bariatric surgery, of course. For someone who has overweight, actually maybe 90% of our kind of patient, diabetic patient, is overweight. So it's very, very common for you to educate patient with diabetes with overweight. So you have to really know what you should say to the patient. For example, if the patient is overweight, which the BMI, let's say, is 30. So if the BMI 30, if you want to go for the normal weight BMI, then you have to lose let's say you have to lose 20 kilograms. If you have to lose 20 kilograms for someone who is very, very old, let's say for 70 years old women, then it's going to be really, really difficult for her to do that. So make sure what you say to the patient is a realistic education. So if you say that this is an overweight patient and you want them to reduce her weight, don't say, okay, ma'am, you have to lose 30 kilograms of your body weight. No, don't say that, okay? Because it's not realistic. If you want to lose 30 kilograms, then you go for Dr. Mui, okay? But you don't do that. It's not very easy to go for bariatric surgery. So if you want her or him to lose the weight, then make sure whatever you educate the patient is going to, she or he's going to do it in a maintained life, so forever lifestyle. For example, what kind of exercise you can do? Okay, I can walk. Oh, okay, so let's do the walk at least 3 times per week. So don't push her into, no. The best exercise for you is swimming, because you have an osteoarthritis on your knee. So the best one is swimming. But I don't have a swimming pool, doc. I don't care. You get the swimming pool, maybe from your neighbor or something. Don't do that. So make sure whatever design or whatever lifestyle you're going to educate the patient, that they gonna do it for long term. So that is for the exercise, and also for diet. You cannot say them, don't eat A, don't eat B, don't eat C, don't eat blah, blah, blah. So you mentioned 10 food, which is very, very delicious for her. And you said, don't eat that or you're gonna get the worst diabetes. Don't say that. So make sure whatever you say is going to increase her confidence. So if you say, okay, ma'am, you see, after you eat this, you see the excursion of your blood glucose is high. So you know you don't eat this. If you eat, then it's going to increase. So you analyze yourself. If she does self-glucose monitoring, then she realized what kind of food that increasing her blood glucose. Make sure that she understand that. So they gonna stop, or they're going to avoid that kind of food or drink anymore. So what I want you to understand is whatever lifestyle that you're going to educate, make sure that they can do it, and they can do it in the long term. Don't trust them if they say, okay, I lose my weight for 10 kilograms in 2 weeks. Let's wait for about 2 months or 3 months. It's going to gain weight again. So we don't want that. Make sure she lose the weight very, very slowly, but in the long term, they still can have it. Okay? I hope you understand that.
Okay, thank you very much, Dr. Wisma. Now we are moving to the live questions. We have questions from Muhammad Said Boska. I think Muhammad Said Boska can ask the questions, please.
Yeah, thank you for your the presentation. And I have a question about the bariatric surgery. That after the surgery, what is the recommended number of visits that we should do? What is the follow-up plan following the surgery? Thank you.
So for while conducting bariatric surgery, we usually do it in a specialized center with multidisciplinary approach. Okay. In terms of follow-up, it really depends on the different centers, arrangement, and protocol. Say, for instance, some of the surgeons like to follow up the patients themselves, okay, and some of the centers, they are followed by primary physicians or even endocrinologists or even healthcare physician, assistant physicians. So it really depends on the different protocol or different centers. But the important point is it should be a multidisciplinary approach. It should be have a long-term follow-up program for patients to assess and come back for follow-ups. For my patients, they usually come back every 2 to 3 months to look at the weight problem, diet, and also for regular blood checkings and looking for complications. And it really depends on different centers and different protocol or different practice. But in general, we should recommend long-term follow-up for every of our patients.
Thank you.
Okay, thank you very much, Dr. Wilfred, for answering. We will move to the next panel of questions for Dr. Wismandari from Goldie in Indonesia. How common IDEX apps and...
Jeremy, sorry.
Yeah?
I think Mohammed Syed is just explained what he has asked about the non-invasive therapy. Can I answer that?
Oh, okay, of course, sure.
Okay.
Please explain.
Yeah, from Mohammed Syed Boksha. Thank you very much for your questions. Non-invasive, that you mean non-injectable insulin formulation. I think is a little bit mixed up here. What we mentioned before is non-insulin injectable therapy. Non-insulin injectable therapy, not non-injectable insulin therapy. I think you mixed up a little bit. So we have injectable therapy, which is not insulin, which is GLP-1 receptor agonist. So we call that as a non-insulin injectable therapy, not non-injectable insulin therapy. Okay, so I hope you get that. And the different, yes, it's very different. The way they work is very different. If you talk about GLP-1 receptor agonist, it's completely different how they work with the insulin therapy. I think we need one more day to answer that.
Okay, is that enough? Okay, I think that's enough for the questions. We move to the next questions from Goldie in Indonesia. In Indonesia, how common IDEX is and how is the distributions throughout the country? Please answer this briefly, Dr. Wisma.
I think it's distributed quite well right now. Yes, it's still under process. For example, me, I have a practice in south of Jakarta. Sometimes I don't really know which pharmacy which sell this insulin, so I just text or I called the pharmacy and then I said which pharmacy that you sell the IDEC out, then they will tell me. But yes, it's still on processing. So maybe if you start to prescribe one in one pharmacy, then after that they will put the IDEC apps in that pharmacy. So basically in the business of pharmaceuticals company, they need to be, they need to be one prescription first, and then after that they will put the IDEC out or they will put the new drugs on that pharmacy. But before that, you need to make sure that they have it because it's still new. It's just started this year.
Okay, thank you very much, Dr. Wisma. And we move to the next questions from Saumya. Is there any time for taking IDEC UP's insulin pen, like when to take or when to not?
Yes. I don't know about you, but my biggest meal is my lunch. So if I would use the IDEC ups, that I would use in lunch, because the recommendation is you inject the insulin IDEC ups in the biggest meal. So make sure that is the biggest meal, then you inject it there. So when not, I don't want you to take the IDEC ups without meal. That is something that is very forbidden, because there is a postprandial insulin in it. So you have to take a meal after you inject the IDEC ups. I hope that answered the question.
Okay, thank you very much. We move to the next questions by Muhammad Said Boska. What is the main advantage of IDEC UP from mixed start insulin, which is 30% soluble in insulin and 70% isopan insulin?
Okay. I think it's also in my PowerPoint, but I would love to say it again. The difference is, first is you don't have to make a resuspension. So you don't have to mix the pen or all over again for about 20 seconds. So the IDEC out is already a resuspended, so you don't have to do that. And the second one, the most important thing, is the basal insulin in IDEC out is a really ultra long insulin, basal insulin. So the glycemic control is a lot better if you compare with mixed start or the premixed insulin. And also you don't have what we call that. The main point is the pharmacokinetic and pharmacodynamic is very, very smooth. So the possibility of having hypoglycemia is very, very rare. So this is the advantages of using IDEC as comparing to the older premix insulin. So the first, the easiest one is you don't have to mix it because it's already one color. If the premix is, you can see like a cloud in it. So they don't have it in IDEC as.
Okay, thank you very much. We are moving to the next questions. The questions panel for Dr. Wilfred Mui. Okay, from Kartik in India, why does bariatric surgery lead to the remissions of diabetes? Please, Dr. Mui. Hello, Dr. Mui. Okay, I think we are
problem.
We are reconnecting with Dr. Mui, so we will move to the next questions. I think it's from Muhammad Farouk in Indonesia. For Dr. Wisma, thank you very much, Dr. Wismandari. I would like to ask if there are different outcomes in type 1 and type 2 if they are treated with IDEC ups. Another question is, IDEC ups are safe to be used in patients from other continents of the world? Thank you very much, Doctor.
I think he already asked me that and I already answered. So the outcome is the same, very, very low in hypoglycemia. And also, yes, it's very, very used if you do for the patient in other continent. And this is also the advantages of using IDEC as when you want to you want to go somewhere very, very far. For example, from Indonesia, you want to go to America. Of course, there will be time difference. So in this kind of pen, it's really, really good for you because you don't know which one is night now. Is it night or is it morning? With this pen, you can inject it anytime you want. So the difference is 40 hours and the shortest is 8 hours. So in between that, you can inject it anytime. Let's say you inject it usually every night, but at night, so tonight you forget it. Oh my God, I don't remember to inject it. So you remember it after the morning. So after the morning, then what should I do? You can inject it that morning. That's really safe, and that's really still going to make the blood glucose is very in control. And after that, what you should do, you can inject it again at night on that day. So the main point is, so the time is not just have to be in one exactly time. So 9 p.m., then it has to be always 9 p.m. No, not with this insulin IDECAF. So if you go travel for a very long journey, so it's really, really useful if you use this, because sometimes you don't know which one is night, which one is morning when you are in the plane. So you just inject it anytime you want, as long as it's pre-meal. It has to be pre-meal.
Okay, thank you very much, Dr. Wismandari, for the explanations, and we move to the next questions. I think this is the last questions for Dr. Wilfred Mui from Asikana. What change should be made in, wrong questions from Kartik in India. Why does bariatric surgery lead to the remissions of diabetes? Please.
There are several reasons why we have remissions of diabetes after surgery. Initially, we thought the remission is because of purely weight loss. As we have shown, bariatric surgery induces long-term weight loss, and long-term weight loss may help diabetic remissions. But this is not the only reasons, okay? The other reasons is because we actually controlled or the quantity or the calorie intake during each meal. So in fact, we limit the calorie intake of a patient for each meal for long term. So the control is better. But what more important is we discover the change of gastrointestinal GI hormone after this kind of bariatric, or you can call it metabolic surgery. For instance, we have shown that this increased GLP-1, PYY, and all this kind of GI hormone. In fact, we are using this kind of GI hormones to help to control the glucose. So I think bariatric surgery is a very, very effective way to control diabetes in long term, and in a substantial number of patients we call remissions. The remissions, some of them are long-lasting, but most of them may not be long-lasting in that sense, because diabetic is a progression disease. But we notice after this kind of GI surgery, we have achieved a much better control in the long term. So the mechanism, there are different mechanism for it. I hope you understand what I'm talking.
Okay, thank you very much. Now we are moving to the last questions. This is the questions in the chat room. We are not able to retrieve it at the first time. It's from Samyama from India. As the IDEC-ASP therapy is relatively new, when it is used in combination with other anti-diabetic drugs, are there certain drug interactions or complications we should look out for? Please, Dr. Wisma.
Thank you, Samyana. That's a lovely question, because when you think to start insulin therapy, the first thing you have to consider is hypoglycemia. So when you combine with the insulin therapy, make sure that you don't combine with the drugs which tend to be hypoglycemia. For example, with the sulfonylurea. So make sure if you want to combine with the sulfonylurea, don't use it in the long. Don't use it with the long sulfonylurea. For example, glimepiride or glibenclamide. If you combine with the basal insulin, then you have two drugs which works continuously in one day. So it's going to increase the possibility of having hypoglycemia. And the other thing that you have to consider very, very careful, if you combine the insulin therapy with the thiazolidinedione. What happened? Because if you give thiazolidinedione, for example, pioglitazone, then you're going to increase the patient with a weight gain, because the side effect of the pioglitazone or thiazolidinedione is having edema, retention of the fluid. So they're going to make your patients getting weight gain a lot more. So you know the side effects of having insulin is weight gain. And if you plus with the thiazolidinedione, then it makes the weight gain is a lot more. So that's two things that you have to remember. Make sure if you combine anything, oral or insulin or non-insulin injectable therapy, make sure that they don't have hypoglycemia. And the second one is make sure that it's still safe, especially when they have a chronic kidney disease. They're going to make the insulin in your body is going to more lasting. So if you give insulin, basal insulin, and you give, for example, sulfonylurea, then it's going to increase again more to be having hypoglycemia. So be careful. So the main point is avoid hypoglycemia if you combine anything, and also avoid the side effects.
Okay, thank you very much for the lovely answer, and we would like to thank you very much all the doctors and all the participants for participating in this event. I would like to recap what we have got from this webinar. I would like to read the resume that diabetes management consists of many ways of management as a conservative therapy and a surgery therapy. In the surgery therapy, we have the bariatric surgery, which is bariatric surgery is not only for the cosmetic and weight reducing, but it is also to improve the glycemic control in diabetes patient. Thus, bariatric surgery can done in the obesity patients with a lot of comorbidities and with diabetes to improve the glycemic control. And in the other hand, we can use insulin on several patients with several indications. And we know now that the IDEC ASP is the good insulin of choice to the patients with the insulin naive diabetes, and we can give them to give a better glycemic control with a lower glycated hemoglobins and lower risk of nocturnal hypoglycemia and lower risk of hypoglycemia. That's all for today's sessions. We would like to thank you all the doctors and all the participants for joining. And before we move to the next sessions, we will present the certificates to our lovely speakers.
Thank you so much.
Wait for me to present the certificates, please. The first one, I would like to present the certificates to Dr. Wilfred Mui.
Okay.
I will take a photos together with Dr. Wilfred Mui. Okay, I will take in 3, 2, and 1. Thank you very much, Dr. Wilfred Mui, for joining us and giving very good information about the bariatric surgery. Thank you very much, Dr. Wilfred. And the next one is for Dr. Wismandari. I will present the certificates. A moment, please. Okay, thank you very much, Dr. Wismandari, for joining us. We will take a photo together before we give the certificate. In 1, 2, and 3. Thank you very much, Dr. Wilfred and Dr. Wismandari, for joining us today. And I hope we all get a good insight. Before we will now move to the next questions, next sessions. Now we will get the presentations from the participants that win the World Diabetes Awareness Month competitions. But before we move, please fill the post-test link. Here the post-test link, the tiny.cc/WDAM post-test. However, please fill the post-test links. I will write the post-test link on the chat Zoom because we need to notify the capitalized words. Okay, please all fill the post-test link and the feedback form, please. Now we are moving to the next sessions. We will have the competitions winner announcement of AMSA International World Diabetes Awareness Month competitions. And now we are moving to the online social campaign competitions. The third The third winner is Vena from AMSA Indonesia. And the second winner is Anastasia from AMSA Indonesia. And the first winner is Deves from AMSA India with the title To Stop the Diabetes. Now we will have a presentation from Deves. Now we want Deves to present the screen, please.
Hello, am I audible?
Yes, I can hear you. Congratulations on winning the online social campaign.
Thank you so much, Jeremy. Thank you so much. I'll be sharing my screen soon. Is my screen visible?
Yes, please begin.
Okay. Good afternoon, everyone. First of all, thank you so much for this opportunity. I'm Devesh Chandra, a first-year medical student from JSS Medical College, Mysore, India. So here I will be presenting our online social campaign named as Diabetes Mellitus Stop the Silent Killer. And I would like to introduce you with other authors as well. Aditi Arora, a third-year medical student from Indira Gandhi Government Medical College, Nagpur, India, and Toshani Gupta, a first-year medical student from Indira Gandhi Government Medical College, Nagpur, India. Diabetes is a disease which is taking a strong ground with immense speed, and within the blink of an eye, we'll be witnessing an epidemic. And not soon later, we will reach a stage where most of the population in the world will be in the grips of diabetes mellitus. First of all, let's see the scope of campaign. We have laid out 5 points to focus during the campaign, that is awareness, education, discussion, updates, and creativity. Here is the roadmap of our social campaign. Introduction to diabetes mellitus. A set of posters that has been designed showcasing about the diabetes. It is basically a brochure with all the subheadings such as definition, symptoms, risk factors, diagnosis, causes, and prevention. The brochure can be circulated on all social media platforms. Here is a sample of our 10 poster brochure. These are the first 2 pages of the brochure. Next, we have informative posters. It is basically a set of posters, each from awareness, myth versus fact, and statistical data, that is graphs. We have designed 7 sets of posters taken from each category, which means awareness, myth versus fact, and graphs, to be posted on various social media platforms such as Instagram, Facebook pages, AMSA, official WhatsApp groups, and this can be done for 7 consecutive days. Next, we have designed, also these are the posters which are designed by our authors Toshani Gupta and Aditi Arora. Moving on, we have designed multi-level awareness programs, including informative webinar, quiz, group discussion, video infomercial, and poster competition. The campaign is a culmination of 5 connected events that can easily be organized in every AMSA chapter. We have tried to cover all the aspects related to diabetes mellitus with the help of events such as prevention, awareness, research updates, current stats, and lifestyle changes. Day 1 starts with an inaugural webinar on the topic of diabetes mellitus. The various competitions that have been planned to be announced at the end of the inaugural webinar are: first will be a webinar plus quiz format planned on information and educational aspect of diabetes mellitus by the guest speaker. The quiz participants who scored more than 50% will get a chance to attend the day 3 event, which is group discussion. Second is the group discussion on day 3 among the quiz qualifying participants on the topic of prevention of diabetes mellitus. Third is on day 4, a keynote session on research advancements in diabetes mellitus by our guest speaker is planned, which will be open for all medical students. Fourth is video infomercial competition, and fifth is the poster competition. The poster and the video infomercial competition will commence right after the inaugural webinar with a deadline of next 6 days for submission. Winners of these 2 competitions can be announced on day 7, and the winning posters and videos can be felicitated and posted. The next section is about the online local diabetes event that was organized in AMSA India chapter at national level. Here is the team who worked on online local diabetes event. Organizers were Aurora and myself. Volunteers were Toshani Gupta, Tanishka Kocher, Nandini Goswami, and Shrishti Kishore. The timeline of the event were as follows: a 30-minute webinar, a 15-minute allotted for quiz, keynote and Q&A session by guest speaker, 20 minutes of brainstorming in respective breakout room, presentation of discussed ideas, and announcement of winners. The format was 3 small connected events, that is webinar plus quiz, keynotes from guest speaker, and group description. We first started with an educational webinar of 30 minutes, which was followed by a quiz of 15 minutes. A total of 431 registrations were done, and they attended the webinar on Zoom and via YouTube Live. The webinar was presented by 2 of our team members, Aditi Arora and Tanishka Kocher. It covered the topics such as definition, risk factors, symptoms, clinical features, genetics, diagnosis, why is it likely to be a pandemic, all these topics related to diabetes mellitus type 2. Moving on to the quiz section, 243 medical students participated in the quiz. The participants were allowed 15 minutes to solve, and it was conducted via Google Forms. The top 48 moved to the phase 2, that is the group discussion. Meanwhile, we had a keynote session and Q&A from our guest speaker, Dr. Shyam Kishore, who is a DM endocrinologist from AIMS Delhi, who also enlightened us on the recent updates and their advancement. He also solved the doubts of the participants. The group description. The top 48 were divided into 8 groups comprising of 6 members each. Allotted time was 20, and one representative from each group presented their discussed ideas for an allotted time of 3 minutes. The group discussion was judged by the esteemed guest and judge, Dr. Shyam Kishore sir. So here are a few glimpses of the event. Now coming on to the impact. The webinar helped the students revise the topic and simultaneously showed them the need to curb this impending epidemic. The group helped students challenge their limits and brainstorm on ideas that can be practically implemented for the prevention of diabetes mellitus type 2. They came up with amazing and astonishing ideas within 20 minutes. At last, I would like to end with a quote of Mahatma Gandhi. Thank you.
Okay, thank you very much, Devas, for the great presentations about the online social campaign and local diabetes event that you have been planning. That is very impressive for you and the team, and congratulations to you and the team. And anyone shall ask, please raise your hand or comments in the chat log of Zoom. If there are no questions, I will proceed to the next winner of the competitions. Okay, if there are none, we will be moving to the announcement for the next winners. So I will be presenting my slides. Okay, so congratulations to Fena, Anastasia, and Devas for winning in the online social campaign competitions. Okay, now we are moving to the public poster competitions. For the public poster competitions, the third winner is Josephine from AMSA Indonesia with final score 74.3 with the title of The Ultimate Delight, Prevent Diabetes with a Hearty Piece of Cake. And the second winner is Andrea from AMSA Indonesia with the title of Prevent Diabetes by Staying in Shape. And the first winner is Ade from AMSA Indonesia with the title of Healthy Baby, Happy Mommy, Diabetes-Free Boba for You and Me. Please for Ade to present your screen for the presentations, please. Thank you.
Excuse me.
Yes.
Jeremy, I will be the one who represent Ade because Ade is not able to come.
Okay. Please proceed.
Okay, thank you. Is my screen visible?
Yes.
Okay. Good afternoon to Dr. Wilfred and also Dr. Wismandari, and also people of tomorrow. Today, I, on behalf of my team, Ade Gautama, Ayers Gilbert Ivano College, and also Rani Permata, proudly presents to you on how to improve future generations, starting from early awareness. Healthy baby, happy mommy. Diabetes-free boba for you and me. Gestational diabetes is one of the most common complications in pregnancy, and it is defined as a high blood glucose during pregnancy. Based on its epidemiology, it is common in pregnancies, which stated that 16.9% of pregnant women in reproductive age globally suffer gestational diabetes, and 21.4 million live births in 2013 worldwide is affected by gestational diabetes, while 90% of them are affected in low middle income countries, such as Southeast Asian countries. Many people believe that gestational diabetes is high prevalent, although it remains neglected all around the world. It is affected due to all myth and fact among people. Pregnant women usually believes that gaining more weight means healthy bigger babies, while in contrast, excessive gestational weight gain can lead to deadly complications for the baby and for the mother, namely macrosomia, or increased size of fetus, and also preterm birth, which leads into more complications. They also think that doubling the food portion to fulfill mother and baby need is necessary. It is called as eating for two in pregnancy. Well, in fact, gestational diabetes can be caused by excessive gestational weight gain, which can develop the risk of the mother and also the baby to develop type 2 diabetes in the future, and also can cause deadly complications. Therefore, we propose a simple solution, which is abbreviate to BOBA. B is state for being active by doing moderate regular exercise, O for obeying doctor's therapy, another B for being careful of weight gain, and also A, adopting a healthy diet for eating. Therefore, by doing BOBA, of course, the diabetes-free BOBA, we can achieve during pregnancy, after pregnancy, and also before pregnancy, mothers can have a healthy pregnancy and prevent the chance of both the mother and the baby to develop diabetes in the future, therefore creating better future generations. This is our poster. That's all from us. Thank you for listening, and we would like to present the diabetes-free boba for the better future generations starting from pregnancy. Thank you.
Okay, thank you very much, Ayers. Great presentations from the boba social campaign and the public poster. It's very impressive for you. Thank you very much. And if there are no questions, I will proceed to the announcement of scientific paper winner. And shall we share the screen again? I will share the screen for the scientific paper winner. So shall we move to the congratulations again to Josephine, Andrea, and Ade. And we move to the scientific paper winner. The scientific paper winner is the third winner, comes to Gideon from AMSA Indonesia with the title of Plasma Glycated CD59 level as a novel predictor of gestational diabetes mellitus and adverse outcomes, a systematic review and meta-analysis of case control studies. The second one comes to Brenda from AMSA Indonesia with the title of Efficacy and Safety of Insulin in Type 2 Diabetes Management, Systematic Review of Frequency Adjustment. And the first one is Vincent from Indonesia with Dissecting the Association of Glycated Albumin in Cardiovascular and Renal Outcomes as an Effort in Putting the Brakes on Diabetic Complications, a Systematic Review and Meta-Analysis. Now we will give the stage to the representative of Vincent to present the scientific paper in front of the participants, please. Thank you.
Can everyone hear my voice?
Yes.
And can everyone see my screen?
Yes.
Okay, so I shall start. Greeting doctors, fellow AMSA friends, and all participants. My name is Vincent Karismawang Saputra, representing my team with Muhammad Alifian Remifta Putra and Raya Makarim Penantian from AMSA Indonesia. We would like to broaden our title, Dissecting the Association of Glycated Albumin with Cardiovascular and Renal Outcomes as an Effort in Putting the Brakes on Diabetic Complications, a Systematic Review and Meta-Analysis. And this will be my presentation outline. And beginning with the introduction and overview of the topic, we know that diabetes mellitus is a common metabolic disorder involving the inadequate insulin secretion and impaired action on the target tissues. The American Diabetes Association has classified this into broad 4 main classifications as follows. And the burden of diabetes mellitus has been well illustrated in this International Diabetes Federation picture in this map, which is showing that estimation of 415 million diabetic population suffering from diabetes in 2015, and it is predicted to reach 642 million populations by 2040. And this would be just the picture that it's 5 million people dying from diabetes as compared to other disease. Now we understand that the pathophysiology of diabetes mellitus is very complicated, that it involves multiple organs, not only a single organ of the pancreatic islet. We can see that it's from the triumvirate moving on to the ominous octate until the recently introduced paradigm of egregious 11. And we understand that what is being the burden of diabetes is not only the diabetes mellitus disease itself, but also the complications that makes this disease become costly, which mainly can be classified into microvascular and macrovascular complications. The representative ones would be the kidney and the cardiovascular system as the microvascular and macrovascular complications respectively. And considering that, this is important for us as future physicians to conduct a good glycemic control, and HbA1c or the glycated hemoglobin has been the standard, the gold standard to monitor, and it is reflecting the glycemic measures of 120 days based on the erythrocyte lifespans. However, experts have questions its validity and utility in the settings of anemia, diabetic nephropathy, and other disease that compromises the erythrocyte lifespan. And in this case, we have seen that the beneficial advantage of glycated albumin that is being proposed as it is having the predictive value as suggested by several studies, and it is not affected by the erythrocyte lifespan. This becomes our interest, and this intrigues us to further explore this current state of art issues in endocrinology field. Now, moving on, we are going to talk about the materials and methods that we have utilized in our paper, and this will be the search strategy involving 5 main databases as long as the key search. And we also present our inclusion and exclusion criteria as follows. Now, moving on to the study outcomes, we involve both the renal outcomes and cardiovascular outcomes as the major complications and representative of the microvascular and macrovascular one. And these are illustrated as the microalbuminuria development and any increase of progression to CKD, ESRD. And for the cardiovascular ones, we include those cardiovascular events or progression, as well as deaths due to cardiovascular diseases. For the risk of bias assessment, we utilize the Newcastle-Ottawa scale, or the NOS, with 3 main domains shown as follows, and it has been converted into the AHRQ standards into good, fair, and poor. And the results of our finding after search through 5 databases, we have identified 1,384 at initial search and coming up with 20 papers that will proceed to the quantitative synthesis. Now, this will be the results for our assessment scale of Newcastle-Ottawa for the quality assessment. And overall, the study shows good to fair quality outcomes in general. And this will be the table that represents the study characteristics. And to ease our life, because of that long table, I've already summarized all our findings that we include 7,235 patients, diabetic patients, and the countries, and also the mean age, and also the study design, as well as the other comorbidities. And this will be the study outcomes for the renal outcomes, firstly, and secondly, we have the cardiovascular related outcomes. And now, considering the forest plot that summarized this, the pooled estimate shows that for the renal outcomes, it is represented to have the total 95% confidence interval of 1.98 for the hazard ratio, and this will be the range. And this indicates that higher glycated albumin patients will have higher risk or likelihood of experiencing the renal outcomes, although it is not statistically significant. But the trend still shows that higher GA a worse prognosis. Now, for the cardiovascular outcomes, we can observe the HR of 1.64. It's even higher, but this time it's statistically significant, indicating that the cardiovascular outcomes would be very serious and detrimental to be experienced in groups with higher glycated albumin. And this will be the cardiorenal outcomes represented in odds ratio. And in this case, we can see that similarly increased risk, and also it's statistically significant. Now, moving on to the discussion of the topic. So basically, we have various glycemic measures, and there are 2 main problems that we can identify. First, duration concern, and second, site concern. Duration concern means how certain marker reflects the glycemic condition based on the time that it can reflect. While for the site concern, it's how certain marker lifespan is affected by its site. And within that, we have very common parameters that we are familiar with, such as fasting plasma glucose to our postprandial glucose, and also glycated hemoglobin. All of these are having a duration concern limitation. Since the earlier 2, we can illustrate that short-term lifestyle changes will then, let's say you want to do examination tomorrow, and you then have that very short diet, and Hence, it will then give a false interpretation of the results for the FPG and the 2-hour postprandial glucose. As for the glycated hemoglobin, it can only reflect duration that is quite long, around 2 until 3 months. Now, moving on for the side concern limitation, HbA1c is concerned with the erythrocyte lifespan, as I already mentioned, and hence in situations such as pregnancy, blood transfusion, cardiovascular complications, diabetic nephropathy, and anemia, this would then lead to false interpretation. And to tackle these two problems, we propose the glycated albumin based on evidence and the studies that suggest its benefit, that it is reflecting the intermediate glycemic index, meaning that it is only 2 to 3 weeks, not too long, but not too short, and it is unaffected by the red blood cells lifespan. And a glimpse of the molecular mechanism on why higher GA can increase the risk or likelihood of experiencing the cardiorenal outcomes is illustrated as follows. Basically, increased GA in diabetic patients would then stimulate the signaling cascade of the TGF-beta system, leading to expansion of the mesangial areas, which means reduction in the filtration units and reduced EGFR. As for the GA, it also exerts, glycated albumin also exerts augmentation of the oxidative stress, and it upregulates the VEGF, and this would then causes microstructural changes, in short, which is prone for conditions such as cellular activation, plaque formation, and atherogenesis, leading towards cardiovascular outcomes, of course. And for the implications of clinical practice, we can observe that the higher GA levels increase the risk of both renal and cardiovascular related outcomes in diabetic populations. And a take-home message for the clinicians and touching on the clinical applicability, this can be a potential marker for monitoring the glycemic control on circumstances which affect the red blood cell lifespan. So this would be the strengths and limitations of our studies. And to conclude, glycated albumin is a potential marker, especially in circumstances where RBC is affected. And this would be good to predict the risk of cardiovascular and renal outcomes. And GA can accurately reflect the glycemic control and help monitoring the progress of microvascular and macrovascular diabetic complications, indicating the need to put on the brakes in preventing this kind of complications. And now we have understood this paradigm of cardiovascular, renal, metabolic, out then to foster the spirit and awareness in conducting studies to take care of these organs and saving our organs, preventing macrovascular and microvascular complications. And this would be the references to our studies. And thank you very much for the attention.
Okay, thank you very much, Vincent, for the enlightenment in the scientific paper aspect of the glycaemie that we can do into the management of diabetes. And this marks the end of the World Diabetes Awareness Month webinar by AMSA International. We would like to thank our speakers, the Dr. Mui and Dr. Wisma that I think already left. We would like to thank you very much for the participations and for the knowledge shared, and also for all participants, all the competitions participants and all the winners. Congratulations, you are all heroes and you are all winners. And would like to close with this statement, happy World Diabetes Awareness Month Day. And I hope with this day we can get more motivation and more enlightenment about how to tackle diabetes and how to prevent it. And that's all for today. We hope to see you all on the next events. Good evening, stay healthy and stay awesome. Thank you very much.